Welcome everyone, and welcome back to our LGDA Presents 101 series, the basics of complex lymphatic anomalies. Super excited to see such a great turnout today. In this series of webinars, we have covered so far, if you've been with us, genetics, the diagnosis, research, and today, which is super important, what are complex lymphatic anomalies? Now, the goal of our LGDA 101 series is that we are going to talk about 5 educational important topics, and they're aimed for you, our patients, families, and even the primary care community in preparation for, most importantly, our International LGDA Scientific Conference. And that's taking place on Saturday, October 2nd and 3rd, 2021. And we would love to see you all there. Now, if you've attended the previous 3 seminars, I've given you a little background, very short, about what complex lymphatic anomalies are. However, I can skip this today because our webinar number 4 is entitled Complex Lymphatic Anomalies 101, an overview for the layperson. And I am super excited today, super excited to introduce Dr. Manuel Carcao, MD, and he is a clinician investigator and hematologist in the Division of Hematology, Oncology, and professor of pediatrics at the University of Toronto. So we have an international doc here with us today. He's director of the Haemophilia and Bleeding Disorders Program at the Hospital for Sick Children. Dr. Carcao received his medical degree in 1990 and a Master's of Science degree in Clinical Epidemiology in 2007 from the University of Toronto, and he joined the Division of Hem-Onc as a faculty member in 1999. As well, Dr. Carcao was president of the Association of the Haemophilia Clinic Directors of Canada and chair of the Canadian Pediatric Thrombosis and Hemostasis Network. He's the author of, amazingly, 160 peer-reviewed papers and textbook chapters. His research, which is important to all of us, includes congenital bleeding disorders, genetics, prophylaxic needs, pharmacokinetics, that's the drug levels, and inhibitor development, childhood immune thrombocytopenia, hereditary spherocytosis, and the most important for us today, the medical management of vascular malformations. So with that, and just personally, I've shared something with all of you each time that we've done these conferences, and this is personal for me because I want to tell you, I reached out to Dr. Carcao in a situation where I needed help with our son, Michael, and he was there for us. And with that, I thank you and say how wonderful and excited we are to have you present today. So I will stop sharing and let you take it over.
Okay. And
there we go. It's
all right.
It's perfect.
And okay, so, well, thank you very much, Kimberly, for the kind introduction and for asking me to speak to all of you today. I will be talking about complex lymphatic anomalies for the layperson, but really for anybody, I think. Mm-hmm. So before I actually do, I do want to say a few words about who I am. Because I think when it comes to vascular anomalies, essentially nobody trained as a vascular anomalist. We've all become that or are gradually becoming that. So who am I? Well, I'm a Torontonian. I was born and raised here in Toronto. And as such, I'm a Canadian. I work at the Hospital for Sick Children, and I have been here for about 30 years in total. The first 7 or 8 in training, and then 23 or so, 22, 23 in as a staff physician. And the arrow is pointing to where my office is and where I'm sitting right now at the Hospital for Sick Children, which is a downtown Toronto hospital. What you're seeing there in front of your screen is the old building. This building is going to come down in the next 3 to 4 years, and we will have a brand new tower. And so it's modifying greatly the institution. I am a professor of pediatrics and director of the Hemophilia and Hemostasis program. And in essence, I'm really a benign hematology doctor. I'm not an oncologist, although I used to do a lot of oncology about 20 or so years ago. And my interests have generally been in hemophilia and bleeding disorders, ITP, and hemolytic disorders, and more recently in vascular anomalies. So how did I, a benign hematologist, come into the field of vascular anomalies? And I think it's always interesting to know, how did people get into this area? So if you go back about 10 years ago, so prior to 2012, here in our institution, we actually had 2 clinics that kind of looked after patients with various types of vascular anomalies. We had a vascular tumor clinic, which was a dermatology-run clinic, and it looked after patients with hemangiomas, which for the most part are very simple, small lesions that don't require any therapy, but there are some complex hemangiomas. And we had a vascular malformation clinic, which was a surgery and interventional radiology clinic that would do surgery or interventional radiology like sclerotherapy. But we had nothing else other than this. And I was involved a little bit because some patients with complex hemangiomas, mainly Kaposiform hemangioendothelioma, these patients needed Vincristine. And Vincristine is a chemotherapy drug. And so I would see these patients and I would administer chemotherapy, Vincristine, to them. And I would have about 1 or 2 patients every year. The problem with Vincristine is that there's a lot of issues with it. First of all, I had to administer 20 weekly doses. So once a week, these children would come to the clinic and would get an intravenous injection of Vincristine. They didn't like the fact it was intravenous. In very young children, you need to put in a special IV to administer Vincristine, an IV called a PICC line. And it had a lot of adverse effects, things like neuropathies and a syndrome called SIADH, or syndrome of inappropriate antidiuretic hormone. And unfortunately, even after 20 weeks of doing this, and the lesions, the Kaposiform hemangioendotheliomas, would respond, but then they would start to regrow after those 20 weeks, and I would have to do it again. So it was very problematic. And then things changed when this report from the group led by Denise Adams, shown here, while she was still in Cincinnati at the time, published their first report describing the successful use of Serolimits in patients, including one patient with a Kaposiform hemangioendothelioma. And they generally showed positive responses, so good response to Serolimits with limited toxicity. And so shortly after that, in 2012, I was referred this 2-year-old boy with a Kaposiform hemangioendothelioma of his right thigh that you can see there in the picture. And I talked to the family, and they did not want to go on Vincristine as they feared the side effects of Vincristine. So I said to the family, okay, let's try Serolimits. And so this was the first patient treated with Serolimits for a vascular anomaly at Sick Kids. And he did very well. After 3 months of Serolimits, his lesion was much less red, much less swollen, less warm, and less painful. And so very quickly, as a result of that, I basically abandoned Vincristine, and I switched these patients to Serolimits, and I started using Serolimits for these Kaposiform hemangioendotheliomas. But when I mentioned this paper that I just showed you, you should note that included in the 6 children were 5 with lymphatic malformations. And so when I saw this paper, I started thinking, I think I'm going to start getting a lot of patients referred to me for Serolimits therapy for lymphatic malformations. And I actually asked the Vascular Malformation Clinic, how many patients do you follow here at Sick Kids? And they said something like, well, somewhere between 600 and 1,000 patients. And I thought, oh my God, I'm going to get a lot of patients. And I did. I started getting lots of patients. And of course, some of these patients you remember more vividly than others. So this is one of these patients. So this little girl was 4 years old at the time when I first met her in March 2015. And she had this veno-lymphatic malformation of her tongue and the base of her mouth. This had been present since birth, and she had never been able to close her mouth. The way you see it on this image is the way she was when she was born, although of course she was much smaller. Needless to say, with this, she couldn't breathe, so she needed a tracheostomy tube to allow her to breathe. She needed a G tube, so a tube directly into her stomach to feed her. And she had to have all of her primary teeth removed by a dentist because otherwise they would impale into this lymphatic malformation and cause bleeding. Needless to say, this also caused tremendous psychosocial issues for both her and her parents. This is the imaging. This is an MRI of her showing the mass. And since most of you are not radiologists, nor am I, I'm going to point out the malformation. You can see that her entire mouth was completely full of this lymphatic malformation. You also see the site of the tracheostomy in her. I started her on Serolimits in March 2015, and within 2 months, the mass was already smaller. 2 years later, it was much smaller, and it continued to get smaller and smaller over time. And the last image I'm showing you is 2018, but it's continued to get smaller since then. Seeing the mass from the side view, you can see how it shrank over time, and it's continued to shrink. And so this really made me very interested in this field because we can do a lot of good for our patients. But we have a lot of patients. So these are just a few of my patients here at Sick Kids with showing you a number of their vascular malformations. So our experience of using Serolimits for vascular tumors and vascular malformations was published a few years ago, so in 2019, and it described our experience up until 2018. And at that point, we had already put in 45 patients on Serolimits. But since then, we have another 100 patients that have come to me. And so I now have somewhere around 150 patients with various types of vascular malformations. And these patients are on Serolimits, the vast majority, but many patients are now on trametinib, or I even have some patients now on alpelisib. And of course, with 145 to 150 patients, I can't show you pictures on all of them, but these are examples of some of these vascular malformations. So the burden of disease is tremendous in vascular anomalies, and the need for treatments is also tremendous. So that's how I got into this. And I think it's useful to know how people got into this because we're seeing people get into vascular anomalies that come from the world of oncology, the world of hematology, of dermatology, of pediatrics, possibly internal medicine, and other fields. So now let's talk about what we're here to talk about, which is complex lymphatic anomalies. But to do so, we have to think about lymphatic anomalies in general. And these can be divided into simple or solitary lymphatic anomalies, and these complex, and for the most part, multifocal lymphatic anomalies. And I'm going to talk about each of these, so I'm not going to dwell on this slide right now, as I'm going to talk about all of these things. But I think in order to talk about lymphatic anomalies, we have to all be able to better understand the lymphatic system, and also a little bit about the genetics of vascular anomalies to really understand lymphatic anomalies and complex lymphatic anomalies. So to talk about lymphatics, we have to actually start by talking about vascular structures. So everybody knows about some vascular structures. Everybody who's listening in on this call knows that they have arteries, that they have capillaries, that they have veins, and that these things carry blood. And we all know this because we see veins. If you right now, wherever you're sitting, look at your hand, you're going to see veins in your hand. We all see veins. We see capillaries. And we feel arteries when you take a pulse. So we know that these things exist, and we know that they're everywhere in our body. And you know that because if you cut yourself, doesn't matter where you cut yourself, you can cut yourself in your foot, in your hand, or your face. It bleeds. It bleeds from everywhere. So blood is everywhere because arteries, capillaries, and veins are everywhere. But what about lymphatics? And most people, maybe not the people on this call, but most of the people everywhere don't know anything about lymphatics. Many people have never even heard the word lymphatics. And the reason is that you don't see lymphatics. You can't look at your hand and see lymphatics. You won't see them. We don't feel lymphatics. There's no pulse in them. But despite that, they're everywhere. Wherever you have arteries, capillaries, and veins, essentially you have lymphatics. But everybody has kind of heard the word lymph nodes. So I think most people would think, are lymph nodes related to lymphatics? And the answer is yes, they are related. There is a relationship between them, which I will describe. So what are lymphatics? Well, lymphatics are in essence tiny tubes found throughout our entire body. And along their path in certain locations, there are lymph nodes. And that's shown here in this diagram where you have these long little tubes that start in our feet, go all the way up, start in our hands, go all the way up, bringing or returning fluid to the center part of our body. But as these tubes go up, you see these little round things, these little nodes. Those are lymph nodes. Hence, lymph nodes are part of the lymphatic system. What do lymphatics do? To understand that, you have to think about blood vessels and what they're doing. So blood vessels are delivering things to our cells, to our tissues, all over our body. So blood gets transported initially through arteries, taking blood away from the heart towards our tissues. Arteries become smaller arteries, which then become even smaller, called arterioles. And finally, these go into capillaries. At capillaries, that's where exchange of stuff is happening. And we need that in order to essentially feed our cells or feed our tissues. We have to deliver a lot of things to our tissues. And so blood contains a lot of stuff. It contains water. It contains blood cells like red blood cells, white blood cells, platelets. It contains proteins. It contains nutrients that we've absorbed through our intestines. And it contains oxygen. And all of these things, to one extent or another, are going to be delivered to cells. Cells need oxygen. Cells need nutrients. Cells need proteins. And so we deliver these components of blood to our tissues. And so every day, leaving our capillaries is about 20 liters per day. Now, we only have about 5 liters of blood. So we can't deliver 20 liters every day without somehow blood or fluid returning into our blood vessels. So every day, 20 liters leaves our capillaries, but 17 liters returns back into our capillaries, which means that every day we lose about 3 liters from our blood. So, of course, we only have 5 liters. So if you lost 3 liters, you would only be left with 2. Well, that does not happen because all of this every day is being returned, and it's going to be returned back into our circulation through our lymphatics, which I will show in a second. So blood is leaving the capillaries at the sort of the beginning part of the capillaries, or not blood, but components of blood, water, proteins, nutrients, and oxygen. And then a whole bunch of it is returning as well. And so what do lymphatics do? Well, they collect that extra fluid that leaves our capillaries and doesn't return to our capillaries, that roughly 3 liters per day. And so these lymphatics shown here in green are these tubes that collect this fluid that's forced out of capillaries and eventually bring it back into the circulation. And lymphatic fluid, which is what's in these lymphatics, is different from blood. And the main difference is that lymphatic fluid doesn't have the blood cells because the blood cells don't leave the capillaries. They're too big to leave. But it does have water, it does have protein, and it does have nutrients. It doesn't really have oxygen because the oxygen is used up by the cells. And And so that lymphatic fluid every day has to be returned back to our circulation. The other thing to take note of this is that these lymphatics have these tiny little valves. You see that within the lymphatics, there's these little things right over here. I'm maybe not pointing exactly the right spot, but these are little valves. And this forces the lymphatic fluid to go in one direction, and it can't go back because the valves would close. So that was the first role of lymphatics, to collect all that fluid that that leaves our capillaries and doesn't go back into our capillaries, and to return it back to our bloodstream. The second role is that lymphatics are everywhere, and they're everywhere, including our abdomen. And there, the role of lymphatics is to absorb fats. And they do so as these things called chylomicrons, which are basically groups of fat that come together to form like this globular structure. And that does not go into the blood vessels right away. It goes into lymphatics. And so the lymphatics will transport these absorbed dietary fats as chylomicrons from the GI tract, eventually back to the bloodstream. So that's role number 2. And role number 3 now has to do with the lymph nodes. So lymph nodes are sites where many lymphatics come together and meet the immune cells in lymph nodes. It is in these lymph nodes where if a person has an infection, for example, an infection caused by a bacteria. So let's say that you have an infection in your toe, and there's bacteria in your toe. Well, in most cases, the bacteria will not be in your bloodstream unless you get really, really, really sick. But if you have the infection in your toe, then what happens is some of that bacteria will get into your lymphatics in your toe. They will be brought up to your lymph nodes, and there, those bacteria will be seen by T cells, B cells, and other immune cells, and also by macrophages. And these things will then start an immune response against the bacteria by producing antibodies and by producing activated white blood cells, which then get released from those lymph nodes and ultimately go into your bloodstream to try to protect your entire body from these bacteria. The bacteria also will get destroyed within these lymph nodes so that they don't go further and infect the patient further. So this is role number 3 of the lymphatic system, is a role in the immune system to bring bacteria and viruses to the attention of the immune system. So what do lymphatics do? 3 things: collect the fluid forced out of capillaries, bring it back into circulation, transport absorbed dietary fats, and bring bacteria and viruses to the attention of the immune system. So those are very important roles. We could not live without a lymphatic system. Now, of course, lymphatic fluid must return at all times back to the venous circulation. So this is happening constantly. And it does so through these large central conducting lymphatic vessels shown here and with the box, the green box on them. These include what's called the cisterna chyla, the thoracic duct, and the right lymphatic duct. So these are big lymphatics, and by big, they're not that big, but they're big in relation to the rest of the lymphatics. And they're in the middle part of our sort of chest and abdomen. And they're bringing the lymphatic fluid back to the veins. And those are veins that are found in our neck area, and they are the subclavian veins, the right and left subclavian veins. Now, this movement of lymph fluid is aided by the fact that there's valves in the lymphatics that only allow the lymphatic fluid to flow in one direction. And then there are smooth and skeletal muscles that are contracting and forcing the lymphatic fluid to go upwards towards the neck area. So what are lymphatic malformations? Well, instead of having normal lymphatics shown on the left-hand side here, where you have these nice little tubes with some lymph nodes in between, and the flow of the lymph fluid is in one direction, and it's working quite well. When you have a lymphatic malformation, as the name implies, that's not, they're malformed. So you don't have these nice little tubes. What you have is you have obstructions or blockages, and these lead to both micro and macro cysts. So that macrocyst in the middle, that's going to be full of lymphatic fluid. And you can have a patient that has many, many macrocysts, many, 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 many microcysts. And so here's an example. This is a girl with a lymphatic malformation in her cheek, in her left cheek. And this is when she's younger, picture A, and picture B when she's a bit older. So this is probably a macrocyst, maybe some microcysts in there too. This is a patient of mine. This is when he was 1 day of age. And the arrows are pointing towards areas where there are macrocysts in red or microcysts in that sort of orangey color. So these are big collections of lymphatic fluid, these cysts. Now, these simple localized lymphatic malformations can be anywhere. Often they're in the neck, as I showed you with these pictures, the neck and the face region. And here they tend to often be very macrocystic, but they can also be anywhere in your body, in the legs, the arms, the abdomen, the thorax. And here they tend to be microcystic. They can also be seen in combination with other vascular malformations, such as venous, capillary, or arterial venous malformations. And they can be seen as part of syndromes like something called KTS or Klippel-Trenaunay syndrome or Clove syndrome or Proteus syndrome. But all of these tend to be solitary. So you have one lymphatic malformation somewhere in your body. But then there are the complex lymphatic anomalies. And so there are 4 of them. And I'll go through each of them individually. So the first is a generalized lymphatic anomaly, or GLA, also known in the past as lymphangiomatosis, but we tend to prefer the term GLA. The second is Gorham-Stout disease, also known as vanishing bone disease. The third is Kaposiform lymphangiomatosis, or KLA. Now, these 3 are all quite similar. They're all multifocal. So you have abnormalities or anomalies in multiple organs, particularly the bones, the liver, the spleen, the lungs, and various soft tissues. And then the 4th complex lymphatic anomaly is CCLA, or central conducting lymphatic anomaly. And this is really a problem with the flow of lymphatic fluid through those large central conducting lymphatics, the thoracic duct in particular. So a few words about each of these. So GLA. So to think about GLA, one would think about this as being a multifocal lymphatic malformation, meaning lymphatic malformation in many places with effusions. That really is probably the pathognomonic of this condition. So you can have micro and macrocystic lymphatic malformations. They can be anywhere, but particularly the spleen, the liver, the lungs, and the bones. Now, the bone involvement in GLA, although bones can be involved, bones are not going to be destroyed by the GLA. So there's no bone destruction. That's very important when you differentiate this from the next one, which I will tell you. There's accumulation of lymphatic fluid in many different places, and all of that is abnormal. It shouldn't be there. So it could be in the pleural space, which is the space around the lungs. It could be in the peritoneum, causing what is known as ascites and giving you a very enlarged abdomen. And all of this may result in a low albumin levels when you check a person's blood, low immunoglobulin levels, and low lymphocyte counts. So blood tests become important to look for these things. The second one is Gorham-Stout disease, or GSD, also known as vanishing bone disease. And this is actually very similar to GLA. Most of the things that I'm showing you right there, I just showed you right here. The major difference is the bones. So in Gorham-Stout disease, the lymphatic vessels, these abnormal lymphatic vessels, attack or basically grow into the bones and result in lytic lesions or holes in the bones. And they may completely destroy the entire bone of a person, or in multiple bones of a person. So really, Gorham-Stout disease, one always thinks bones. And then there's Kaposiform lymphangiomatosis, or KLA. And again, this is actually very similar to GLA, except in KLA, there is, in addition to all the various features of GLA, there's a lot of hematological abnormalities with low platelet counts, low fibrinogen. And these two things lead to bleeding. And that's often bleeding into the lymphatic effusions, the pleural effusion, the ascites, the pericardial effusions. And this could be a very aggressive condition. From a pathology point of view, it also looks a little bit different from GLA if you get pathology, meaning if you get a sample of affected tissue, because here you get these particular cells called, or these spindle-shaped lymphocyte endothelial cells, which look, or lymphatic endothelial cells, which look different than what you would see in GLA. When do you suspect these three conditions, GLA, GSD, or KLA? Well, when you have multiple lymphatic malformations, so multiple tissues are involved, not just one, and you then have any of these things, bone lesions, effusions, like a pleural effusion or a pericardial effusion or a peritoneal effusion, and then and you have protein-losing enteropathy. And these things often and will result in malnutrition because you're losing a lot of things, including fat, because you need your lymphatics to absorb fat and to ultimately deliver it back into your circulation. So often you'll get malnourished if you have these things. The last one is central conducting lymphatic anomaly, or CCLA. And here it really is a problem in those main lymphatics in the central part of our body, in our abdomen and chest. And it's particularly in the thoracic duct. And the end result of that is there's essentially a blockage. The fluid, the lymphatic fluid, is just not returning the way it should back into the venous circulation. And so fluid will accumulate and will result in effusions, pleural effusions like a chylothorax, pericardial effusions with an effusion around the heart, ascites with an effusion in the peritoneum. And it can also result in lymphedema, with the legs, for example, becoming very swollen, or the arms becoming very swollen. And again, all of these things will result in malnutrition. So in order to distinguish these things, we tend to use things like imaging studies, MRIs, CT scans, bone scans, to look at these complex lymphatic anomalies. So unfortunately, it's still not easy to distinguish between these. And often a person is sort of described as, do they have a GLA or do they have a KLA? Because they're not that easy to distinguish. Now, Gorham-Stout should be distinguishable by the fact that there is bone destruction. And the bone, it's the cortex, or the outer part of the bone, that gets destroyed. And so you can see that, particularly on a bone scan, but also on a CT scan. In central conducting lymphatic anomaly, the main problems are in those central lymphatics. And you can see that by doing an MRI, lymphangiogram, or other ways of imaging. But you can sort of see it. But when it comes to GLA and KLA, it's not easy to distinguish these radiologically. We do blood tests as well. And there are certain things that we look at, the albumin, the immunoglobulin levels, the fibrinogen levels. But again, it's not easy to completely distinguish, particularly GLA from KLA. Although with KLA, we look for a low platelet count and for a low fibrinogen level. And that, if you see that, then it becomes relatively sure that you're dealing with a KLA and not a GLA. But in order to really distinguish these, genetics becomes important. So I'm now going to talk a little bit about the genetics of vascular anomalies. Now, before talking about the genetics of vascular anomalies, I want to bring to your attention that we all start, all of us, as one cell. That's a fertilized egg. That's how we all start. We start as this unbelievably tiny little thing. That's one egg. And that fertilized egg carries our germline. Our germline, all of our genes that we've inherited from our father through father's sperm cell, and from our mother through our mother's egg. And these come together to form us. And our germline, meaning the collection of all of our genetic makeup, consists of 3 billion pieces of information called nucleotides. And these 3 billion nucleotides make up about 30,000 genes. So we consist of about 30,000 genes. And every one of our cells has those 30,000 genes. So, of course, we start off as one cell, but that cell very quickly becomes 2 cells because it divides. And those 2 cells divide to form 4 cells and 8 cells and 16 cells and 32, et cetera, et cetera, et cetera. Until finally, we, as adults, consist of about 30 trillion cells, which is an astronomical amount. I guess about the same as the US, the US debt. And so every one of our cells contains 30,000 genes. And so any mutation that we inherit from our parents will be in our germline, and it will be in every single one of our cells. So things like sickle cell disease, Down syndrome, hemophilia, those would be in every single one of our cells. So if you take a blood test, for example, you can check for sickle cell disease or Down syndrome or hemophilia, because our blood cells will have this as well. But there's a different type of mutation, not a germline mutation, but what's called a somatic mutation. So somatic mutations are mutations that occur when an embryo is developing. And unlike germ cell mutations, these are present in only some cells in the child. So for example, if as the child is developing, very early on in the development, if one cell becomes mutated, then that one mutated cell becomes 2 mutated cells, becomes 4 mutated cells, et cetera. And eventually, it could be, for example, that a child's foot has a mutation, let's say a lymphatic malformation in that. And so here, only some cells in the child are mutated. So somatic mutations occur in early embryogenesis. It could occur in the first few days of embryogenesis, or the first 1 or 2 or 3 weeks. And the earlier that it occurs, the larger and more devastating the ultimate impact is. So complex lymphatic anomalies probably arise from mutations that occur much earlier than some of the simple lymphatic malformations that we see. And so when you have these types of somatic mutations, the child is really a mosaic of normal cells and abnormal cells. So if you do a blood test here, it's probably not going to be useful because in most cases, the blood itself will consist of normal cells. And it's only if you get the tissue that's affected that you will find abnormal cells. Now, in order to understand the genetics of vascular malformations, we have to think about the various genes that are involved. And shown here are various genes in those red circles. So for example, you see over here KRAS and NRAS and ARAF and BRAF and PIK3CA, etc. These are all different genes that we think, and many scientists, and this comes from a group in Belgium, think are involved in the development of vascular anomalies. And these mutations in these genes result in different types of vascular anomalies, which are shown here in these purple. So things like, and you see there, vascular malformations, VM, LM, lymphatic malformations, KTS or Klippel-Trenaunay syndrome, etc. And so if you have a mutation in one of these things, so for example, over here, ARAF, if you have a mutation there, you may have, as a result, CCLA, if you have a somatic mutation there. Now, these groups of genes are part of 2 pathways. So you have these 2 big circles, the RAS MAP kinase ERK pathway and the PIK3 AKT mTOR pathway. And both of these pathways involve these genes that are involved in vascular growth and differentiation. So that's the growth and differentiation of vascular structures. arteries, veins, capillaries, and lymphatics. So if there's a problem with these genes, you can have a problem with arteries, veins, capillaries, and lymphatics. So as you're going to see here, if you had a problem with the PIK3CA gene, for example, the end result is you may have abnormal vascular growth and differentiation, and that might give you a condition like GLA in some patients if it occurred early on. And if it occurred a little bit later in the development of the embryo, it may just give you a localized lymphatic malformation. And different mutations may result in different diseases, different types of vascular anomalies. Now, the genes involved in complex lymphatic anomalies, the things that I showed you before, are shown here. So you can see those little black boxes with underneath a yellow line. So GLA, that involves, the best understanding that we have is that those are caused by mutations in PIK3CA. KLA, mutations in NRAS, CCLA in ARAF, and also CCLA up here from EPHB4. So all of these genes, if you have a mutation, if some cells have a mutation in those genes, it could ultimately cause this child, when they're born, to now have these conditions, these complex lymphatic anomalies. But we're learning more. Just recently, in the last couple of years, it's been found that there was a patient with KLA who actually had a mutation in this gene called CBL. And this is another gene that we didn't really know too much about. We still probably don't know that much about, but this interacts with KRAS and NRAS. And this has been found to be involved in KLA. Also, Gorham-Stout disease. There have been some reports showing that that some patients have a KRAS mutation and they present as Gorham-Stout disease. So we're learning a lot more about the genetics of these complex vascular anomalies. And that is useful to distinguish so that if you see a mutation in NRAS, you're thinking KLA. If you see a mutation in PIK3CA, you're thinking GLA. And this, knowing the genetics of these lymphatic anomalies and of vascular anomalies in general, is very important because we now have some drugs that we know work in these pathways. Serolimits, also known as rapamycin, blocks mTOR. And mTOR is part of the PIK3CA pathway. So by blocking mTOR, you block any problems with these genes above, like PIK3CA. Similarly, alpelisib, which blocks PIK3CA, may also have a role in a condition like GLA. Then we have trametinib on the other side. Trametinib is also known as Mekinist. And this blocks the RAS MAP kinase ERK pathway, and it does so down here. So if you have mutations in any of these things up here, perhaps by blocking this pathway, then you will stop this tremendous vascular growth, differentiation, and essentially abnormal growth of these vascular structures. And so just in the last few years, more and more and more patients are being put on these drugs. And now we have a better understanding of how these drugs work. But still, there's only 3 drugs there. We need more drugs. The other thing that complicates this is that these pathways, I'm showing you as 2 pathways, but actually there's a lot of interactions between these pathways. And that means that sometimes patients actually may have to be on sirolimus and trametinib in order to really have a therapeutic benefit. Because if you only block one pathway, perhaps the signal, this abnormal signal for vascular growth and differentiation, goes through the other pathway. So I have several patients who are now on both sirolimus and trametinib, but I try to keep them at a low dose of each. So finally, to end this presentation and to take some questions, I want to just go back a little bit. So clearly, I'm now involved in the medical management of vascular anomalies. There is a lot to learn for both myself and also really for the entire community and for everybody who's now involved in the medical management of these conditions. But we need to develop more treatments for patients. And there's a lot of patients. And so there is a tremendous need to develop more treatments. There's a tremendous need for more research, particularly clinical trials where we can tell and conduct research to see if these drugs and newer drugs work. And finally, we just need more people. We need more people looking after all of these individuals with these vascular anomalies. We need more physicians, we need more nurses, we need more physical therapists, we need more of everything, because there is a tremendous need that hasn't really been fulfilled in this area. And with that, I thank you for your attention. I look forward to taking questions. Thank you very much.
Thank you so incredibly much. That was outstanding, Dr. Carcao, and I think I can speak for everyone. It was clear and really impactful to all of us to understand it better. In fact, I think I now understand the lymphatics even better too. So thank you very much. There are questions coming in, so I don't even have to start with any, which is fantastic. Some of them do cover the drugs that you did discuss, but maybe we can go into it a little bit more. Two of the questions around anything beyond Serolimits for complex GLA, and is the use of bisphosphonates effective? And the second one that's very similar, have any therapies been identified to target the NRAS mutation?
Yeah, so the first one in terms of GLA, from what I showed you with the genetics of these vascular anomalies, it makes sense that you would start off with Serolimits, and that Serolimits could certainly work. I think in the future, alpelisib may have a potential role as well, that for now, it hasn't yet been used in this condition. So that might be an alternative, or you never know, maybe even an additional therapy that you may be able to use them in the future together. But it's not always clear if a person really has GLA. So sometimes it actually may be KLA and not GLA. And I think for patients that fail to respond, one thought is to at least do a trial of trametinib for at least 3 months to see if that would be helpful. I think for biphosphonate use is very important. If bone is being eroded in GSD, then I think you should certainly put patients on biphosphonates, and I have several patients on. When it comes to GLA, that's not as clear, the role of that. I think there may be a role, but I'm not so sure that there is, because the bone disease tends not to destroy the bones. And so if you put the patient on some other therapy like Serolimits, and if it's working, you may not need the biphosphonate therapy. In terms of targeting NRAS, again, NRAS is part of that RAS-MAP kinase ERK pathway. And so trametinib would be right now the only drug that I think is available that you can use, but perhaps in the future there may be targeted therapies that just target NRAS, but I'm not aware of any right now.
You brought up really important pieces of information, and we've talked about this in other of these pre-conference webinars. Can you really mention or talk a little bit more on the importance of the tissue diagnosis, of us really finding the targets so that we can find better medications, and maybe explain a little bit of this whole idea of drug repurposing, which is what we are doing now, right, with these drugs like trametinib and alpelisib?
Yeah, so tissue or obtaining tissue is very important for a multitude of reasons. So the biggest one is genetics. So as I showed you, almost all of these vascular anomalies, including the lymphatic anomalies, are caused by somatic mutations. What that means is that they're not present in every single cell in your blood. They're only present in affected tissue. And so generally, blood tests for genetics are not that useful because your blood cells are fine. They don't have that mutation. So you have to get tissue in order to send it off for genetic testing. So that's one major reason to obtain tissue, is for genetic testing. The other one is to look at the pathology, or meaning to look at the structure of the cells. What do they look like? Because, for example, KLA pathologically looks different than GLA. And so another useful is to get tissue that is looked at by a pathologist that's specialized in looking at these things, so that they can differentiate these conditions. So I think these things make it such that it is very important for patients to, I guess, agree or consent to having the tissue obtained from them by some type of biopsy. In terms of drug repurposing, yes, exactly. I mean, the drugs that I've mentioned, not just alpelisib and trametinib, but also even sirolimus, were not developed simply for vascular anomalies, not at all. They were developed for other reasons, including sirolimus. The sirolimus has been available now for 21 years, and it was used for about a decade for other reasons before it ever became used for any type of vascular anomaly. So we are repurposing a whole bunch of these drugs, and the same thing for trametinib and alpelisib, which are used in several rare types of cancers. So I think eventually in the future, as our understanding improves of vascular anomalies, there may be certain drugs that are developed specifically for vascular anomalies, but I don't think we're there yet. And that's going to be in the future. But yeah, the changes are remarkable. Like, until 2 years ago, I had nobody on anything other than sirolimus. And now I have patients on trametinib, I have patients on alpelisib. And I imagine in 2 years from now, I'll have patients perhaps on other things that we learn about in the next few years.
Yeah, it's progressing so quickly, and it's really great. And that's the hope that we all need. On the topic of sirolimus, someone has asked, do you feel sirolimus is safe for long-term? Will my daughter with GLA be on this forever? And are there long-term problems? And I can personally say, I called my mentor, who's a transplant surgeon, and said, do I have to put Michael on sirolimus? Because I was so worried about it. And his first thing was, just get him started. So that's where we are with it.
Yeah, so when it comes to sirolimus, so there's many questions embedded into what you just said. So one is, how long do you need to treat patients with these drugs? So in general, my approach has been, you treat for a fairly long period of time, but with the goal that you will eventually try to take them off, or at the minimum, reduce the dose to the lowest dose necessary. So I don't like the idea of children being on drugs forever. I've never liked that. I'm not on anything, knock wood, that I don't take any medications. I'm not, so I would rather these patients not be on, but we know that they need to be started, and there should be no reluctance to start. These drugs, like sirolimus, are actually quite safe when you compare them to other drugs. I mean, every single drug, if you take it for a long time, has a lot of side effects. You know, I think of steroids, for example. My God, there's almost nothing that is worse than steroids if you're on it for a long, long, long time. That has so many side effects. In comparison to that, sirolimus has so few side effects in comparison to that. So any drug that you're on for a long time will have some side effects. The side effects with sirolimus are, you know, generally fine. You can get mouth sores, you can get an elevation of cholesterol, triglycerides, a bit of a sore stomach, but those are really quite tolerable. In a long-term fashion, you know, we haven't seen much, but we haven't had patients who are on sirolimus for 20 years straight. So we don't really know that long, but I've had patients who have been on sirolimus now for 8 years straight, and I don't see any side effects, any long-term side effects with them. So I think that they're very safe, but the most important is, as I think you said, Kimberly, get started and don't delay because you're worried about a side effect that might occur 15 years from now. You want to get started, get the benefit in the short term, the next months, year, 2 years, 3 years, and then with time, try if possible to reduce the dose, maybe get the child off of it, and perhaps the child may have to go back on it at some point in time, hopefully for a short period of time.
Right. Excellent. These are terrific. We have one, and I think it's going back. I also want to talk about diet because there's been 2 questions about that, which is always a controversy. So maybe let's do that one first. So there have been 2 questions. Do patients need low-fat diets, or is there something we as a community can be doing with our nutrition, which I think is the right answer, being healthy with our diet, but I'll let you take that one on about fatty diets.
Yeah, so when it comes to diet, so yes, of course, all of us could have a better diet. There's no question. In many respects, so I'm not going to dwell into that. I think everybody needs to watch, how much fat they have, how much red meat. Maybe, you don't want to have red meat twice a day, every single day of your life. You don't want to have so much sugar with soft drinks every single meal. None of that is good for you for long-term health with diabetes, hypertension, hypercholesterolemia, all of that kind of stuff. So, but when it comes to patients with vascular anomalies, the question is, do you handle their diet any differently than everybody else's? I am not a big proponent of, in essence, punishing children or adults for having something like a CCLA by putting them on a low-fat diet, because simply changing their diet isn't in any way fixing their problem. It is a temporizing thing so that you don't see as much chylomicrons in their effusions, but it doesn't solve anything. I've had many patients refer to me where gastroenterologists have restricted their fat for 6 months, but they still have the same problem. So it hasn't helped to fix the problem. It just kind of made them miserable. So I'm not a big proponent of that. I would say, no, that is not the way to go. You need to put them on therapy. Now that therapy could be, trametinib, could be sirolimus, could be a combination of both, but it could also be a number of surgical and interventional radiology procedures, which are important. But deal with the problem by trying to fix the problem, not with putting them on a low-fat diet.
Terrific. I think that's the approach we certainly have taken. At first, I asked the same question because if it's lymphatics and fat, you would think you'd have to, but in the end, you're right. It's the kids are kids, and it didn't really make a whole big difference. Though I still am trying very hard to make it a healthy diet, which in a tween, not easy. So
sure.
Here's another question. My son was recently diagnosed with GSD of the skull base. Is there any reason to suspect that it is elsewhere in his body? And I think that's
sure.
one that I've seen.
The answer is yes. But I would imagine that if the diagnosis was made of GSD of the skull base, that hopefully there was imaging of the rest of the body that would have included a bone scan to see if there was any disease elsewhere, and perhaps a whole body MRI to do the same thing. So I'm hoping that was done and that it was only found to be at the skull base. So, but if they only did an X-ray of the skull and nothing else, then one can't be sure that there isn't disease elsewhere. Right. So as long as the entire body was imaged with bone scans and a whole body MRI, I think then probably it's nowhere else.
I brought that one up because I think it's important. I've seen that question multiple times in our community discussions, and I do wonder, and to make the importance that this is diffuse a lot of the time, and so we do need to make sure and check that it's not in other parts of the body to be able to address it before it gets out of hand. So thank you for answering that one. Okay, we are over time, but there is one more question that I would love just to kind of talk about, we have a guest here who has a child with Noonan-like syndrome and mitochondrial disease. And is there any data on these diseases linked with CCLA? And I thought this was an important one because certainly from my knowledge, yes, there is.
Yeah, so I'm just going to go back to this. You see my slide?
Yes, we do.
Okay, all right. So, so Noonan's is considered to be a RASopathy. And if you can see that, the big circle with the RAS-MAP kinase ERK pathway, those genes are, when they're abnormal, are thought to be what are known as RASopathies. And Noonan's is associated with potentially genetic defects in many of these things, many of these genes that are shown in red over there. So, and as you can see, CCLA is involved in ARAF and in EPHB4. So yes, potentially, we know that patients with Noonan's can have vascular malformations. Many patients do, and possibly CCLA. I haven't seen it, but it makes sense that patients with Noonan's can have this, and you might want to put them or at least try something like trametinib for this condition.
Fantastic. We could keep going and going. So we appreciate this so much. And as we talked earlier when I first met with you, we would love to have you come back because this has been fantastic. I'm just going to stop sharing your screen for a second and just quickly end by letting everyone know that there is, that we have one more pre-conference webinar before our international conference. And this one, unfortunately, I don't have a date yet from the speaker, Dr. Kristen Ricci, but we're going to get it. And this will be on Treatment 101. So this is an excellent segue to that. And we will talk about possible treatments for complex lymphatic anomalies. So with that, a big, heartful, grateful thanks, Dr. Carcao. This was incredible. And if anyone else has any questions, please feel, to reach out to me. I can try and get those answers for you. And we are really just, again, thankful that you are here and enjoyed this so very much. So thank you for your time, and thanks to our community for everyone who's shown up. It was fantastic. And we'll see you for the next one.
Good. Thank you, Kimberly. And thanks to all of you that decided to listen to me, and all the best for you and your family members. 35 plus on today. Okay, good. Okay, everyone, take care. Have a great day.